Well, good afternoon, everyone, and thank you very much for joining us. My name is Simon Lockyer. I'm one of the co-founders of Five Good Friends and the CEO, and I'm joined today by Dr. Paul Griffin. Thanks very much, Paul, for coming along. I'd also like to welcome some of our partners who are with us today. It's really, really important, and we're very grateful that you've joined us. We've got people from retirement villages and from our allied health partners, and also two of our board members, Dr. Nick Woods and Helen Weston, have joined us. We're really grateful that you'd take the time to be here today, and thank you for your support in putting on this webinar. The biggest thanks, though, is for Dr. Paul Griffin. So Dr. Griffin is an infectious disease physician and also microbiologist. He was appointed as the Director of Infectious Diseases at the Mater in 2013, I think. Is that right?
Something like that.
Yep. In addition, he continues appointments as Principal Investigator at QFarm. He's a visiting scientist at the Mater Medical Research Institute and the Queensland Institute of Medical Research. He's also a Senior Lecturer at the University of Queensland. Many of you may have seen Paul. He's become a regular in the media, and he's been providing really clear, concise, objective and easy to understand information on COVID. And Paul, we're just so grateful that you are here and you've made the time to be with us today. I really do want to talk as little as possible today. I think it's most important that we get to listen to Paul and we learn from what Paul has to say. Throughout the course of the last sort of 18 months as we've been living with COVID now, there's started to get a lot of information out there, and some of that information isn't correct. And we felt that it was really important to give everyone an opportunity to start to learn about this and to perhaps to dispel a few of the myths that are out there. And that's really what today is all about. We've received a lot of questions in getting ready for today's webinar, so thank you very much to everyone who's given us that information. If you do have a burning question, as a result of the discussion that we have here today, please just pop it into the chat and we'll do our best to get to that. If not, we will answer every question afterward, and Paul has kindly offered to remain in contact with us and for us to be able to send some of those questions to him. So thanks again, Paul, and we thought we might just start by really with the most basic of questions and say, can you just tell us what COVID-19 is, what this virus is, and why has it been so devastating across the world?
Sure. Well, first of all, thank you for the opportunity to have a chat. I'm always happy to try and spread some of the right information, and particularly talking to an organisation that does such good work like yours, I'm happy to try and help. So this virus, that COVID-19 is actually the name of the disease that it causes. The virus itself is called SARS-CoV-2, which is a bit of a mouthful, which is why we often say COVID-19. And in fact, this is what we call a coronavirus. So it's nothing to do with the beer. It's because it looks like, when we look at it under an electron microscope, it's got a little crown. So that's where that comes from. And they're not a new group of viruses. They've been around since the 60s, in fact. And we've had two nasty coronaviruses in the past. We had the first SARS that people might, might remember from 2003. And the difference with that one is it was actually more severe. So those people got sicker, and that actually made it easier for us to find those and put them in hospital and isolate them. So we got rid of that virus completely with the same sort of infection control measures we're doing with this one. There was another coronavirus in about 2012 called MERS, but that one was actually more severe again and much less infectious. So you had to essentially be associating with camels in the Arabian Peninsula to get that one. So when you look at these viruses, they've been around for ages. There's also a lot of really mild ones that cause colds, but then we had this one. And the trouble with this one is it's probably got just the right mix of properties in that a lot of people aren't that sick, so they go about their day-to-day lives spreading it around. But then, of course, it can be significant enough in enough people that it causes big problems. So it's the right mix of both, I guess. And that's why it's been such a problem, is a lot of people have it, they don't really know, they might fly internationally and transfer that virus to other countries, and that's why we've seen it spread so much. But then in people, particularly people that are vulnerable because they might be older or have comorbidities, it does actually unfortunately kill a significant proportion of those people and make a lot of them very sick. So that's why we need to be really focused on taking this seriously and particularly doing everything we can to try and prevent it. And particularly now, that's in the form of getting everyone vaccinated.
Yeah. So just on that point, Paul, why are our ageing loved ones and our loved ones who are living with disability, why are they so vulnerable to this virus?
Look, it's a good question. All viruses attack different people in different ways. We know with the flu, for example, there are different groups that are most susceptible there. And we've got good data now to show who is most susceptible to significant consequences of this infection. And it is particularly the elderly.
Yeah.
That's perhaps the highest risk group for people that do progress to more severe symptoms. And then those with medical problems. And in terms of exactly why, it's a bit of a complex answer, and perhaps we don't know the full answer there, but we do know those people are more susceptible. So they're the people that we do prioritise in terms of prevention.
Yeah, okay. So we're all sort of being forced to learn our Greek a little, and we've now heard about the Delta variant. I think, was there a Lambda variant as well?
There's lots, and we used to call them based on where they originated from, but people didn't like hearing about the Brazilian strain or the South African strain. But the joke was that now we're calling them all Greek letters, that perhaps the Greeks don't like that every strain is named after them. But
So why is the Delta variant so virulent? What's happened there?
So there's a few properties, and when we see these variants of concern, so variants is something that occur all the time, and what happens there is when this virus reproduces, like all viruses, it makes mistakes. Some of those mistakes make it not survive, and so it just goes away, but some of them give it extra properties that might be favourable from a virus perspective. And when it does that, when it does something like be more infectious or more severe or perhaps evade our vaccines, it goes from a variant or a variant of interest to a variant of concern, such as Delta. And what that one does is it is clearly more capable of infecting people. It's probably twice as infectious as Alpha, which was the UK strain, which was about 1.5 to 2 times as infectious as the original or the Wuhan strain. So the way it's more infectious is still not completely clear. It does appear that people that have that strain maybe produce around 1,000 times more virus, so there's just more virus there. But also it appears a bit more sticky. So we know these viruses have to bind to cells in people to get in, and this one seems a bit better at doing that. So they're the reasons it's more infectious, definitely.
Okay, and is it likely that it's sort of topping out in terms of its evolution, or are we likely to see the virus mutate again and another variant enter the community?
Yeah, we will. It continuously evolves, and it's very likely. So at the moment, the big concern with Delta, in addition to it being more infectious, is how well the vaccines perform. And what's clear is that their performance is reduced, but it's slight.
Right.
So at the moment, our current vaccines do still work very well for Delta. We are most concerned about what we'll call an escape variant. So at some stage, whether it's in days, weeks, months or years, we perhaps will see a new strain that the vaccines don't work well for. But the key there is all the leading vaccine manufacturers are already practicing making new vaccines to new strains. So what will happen is if we do see a new variant the vaccines don't work for, is all those leading manufacturers will simply make an additional one. And what it might be like is every year, just like we get a flu vaccine that includes 4 new strains, is the COVID vaccine might include 1, 2 or 3 strains at that time, so we're protected against all of those circulating strains.
Okay. And with Delta, there's a lot of talk about it affecting young people. We've all seen the story here in the media about, I think, the 30-year-old lady who passed away. Why is that? Why is it so infectious to young people, or is that more that we've got a vaccinated population who are older? Yeah,
great question, and it's probably a bit of both. So, as I said, it's more infectious, and that probably is across the board. And if we look at who's vaccinated, Australia, we're obviously still a long way behind a lot of other countries, but where else Delta is circulating, they have quite high vaccination rates, but most countries have prioritised the elderly for very good reason. So we've kind of pushed down that age now where we see most of the cases, and that goes for the adult population, but also in children. So relatively speaking, we've seen increases in the proportion of children that are infected as well, and it's likely it doesn't have a particular targeting of those kids. It's just that the older groups are getting more and more vaccinated.
Okay. We sort of use the word vaccine like we all really know what they are. And I guess, we've grown up with them, the technology has been around for a long time. But could you just explain to us what they are, how they work, and then from there could we talk about AstraZeneca and Pfizer and what's different about those two?
Oh, absolutely. So what a vaccine is designed to do is expose your immune system to something that's part of that virus, so it's prepared or trained. And what these vaccines do is they switch on all sorts of parts of the immune system so that the next time you encounter those same things, so when you go from getting the vaccine to getting exposed to the virus, your immune system is really well prepared to respond to it much better. And in doing so, it means you're much less likely to get the disease and particularly get really sick from it. So this is how the COVID vaccines work. And what they do in this particular case is there's a little thing on the surface of the virus called the spike protein. And so most of the vaccines that we talk about at the moment contain or help your body make those spike proteins. So in the case of Pfizer, that's what we call an mRNA vaccine. And what that really is it's basically the instructions to make a spike protein. So when we inject that, people that have received that make lots of little spike proteins, and then your immune system recognises that. It does all sorts of really clever things so that when in the future you get exposed to the virus, you're ready to stop it and kill it off and get rid of it. With AstraZeneca, what we do is we put those same instructions for the spike protein inside a harmless virus. So we call that a viral vectored vaccine.
Right.
And that harmless virus carries those instructions into where it needs to be in your body, once again, to make those spike proteins and train your immune system to recognise those and ward them off when you get exposed to them on the surface of the virus.
Okay. And so they sound like they obviously have the same impact, but they work differently. So there's talk in the community now about mixing vaccines. In the UK, they did that. What's the sort of latest thinking on that? Should we be staying with the one vaccine, or are we likely to see people receiving both?
It's a good question, and you know what's really clear is that our vaccine strategy will evolve over time. So when we make changes to that, and maybe we switch to that mix and match strategy, it's not because what we've been doing is wrong or hasn't worked. It's just that we're learning more and more all the time, and we're trying to work out ways to improve how these vaccines work. And in lots of parts of the world, they've done some great studies to show what happens when you give one type and then give another one as a booster. And when we put all that together now, it does appear that your immune response is probably higher.
Right.
And there's no significant problems in doing that. But what we do see when we go from AstraZeneca to Pfizer or vice versa is you do get a few more reactions. So
Right.
not the type of reactions that would stop us doing that, but you're about twice as likely to get the mild things that we kind of expect with vaccines. So things like a fever and a headache.
Okay.
So we haven't made the decision to do that in this country yet, but it's very likely that we will need boosters into the future.
Okay.
And we're still working out exactly when that will be, whether it's every year or 2 years,
Yep.
for example. And what will likely happen, although a lot more stuff to work out between now and then, is when we do give those boosters, it will probably be with the other type.
Yeah, okay. So with AstraZeneca, there's been a lot of talk about the blood clotting and the age thresholds for being able to receive the vaccine, sorry. Can you just talk a bit about that and why that's now starting to change? Why are ATAGI changing their view, or is it more just there's been a misunderstanding of what the advice is?
Yeah, the way to look at that evolving advice is that we've got an excellent regulator in this country, a very rigorous, highly diligent regulator, and ATAGI in particular. They look at how these vaccines work in clinical trials, including animal studies and people, and they then look at how the vaccines are working in the real world. And we're very fortunate to have such huge real world experience with these vaccines now. And their job is to monitor the effect, the benefits, how much they're protecting people, how much COVID's around, versus the risks. So what sort of side effects these vaccines are producing both in our country and everywhere else. And so it became apparent that the AstraZeneca vaccine, which is a highly effective vaccine, was causing this really rare clotting syndrome. And so they monitored that really closely. And when it started to become apparent that the risk of the clotting syndrome was higher in young people, they started increasing the age range in which we recommend that vaccine.
Right.
Now, it's always remained approved for people 18 years and older.
Right.
Because when we look at the risks and benefits...
So that's important. It has always been approved for people.
Absolutely.
Right.
So it's always been the case that if an 18-year-old or older wanted to get that vaccine, it was still perfectly within the approval.
Right.
But just to try and, again, this is a strength of the ongoing process that TGA do, they recommended we prioritise the alternate vaccine in younger people.
Right.
But obviously that's balancing a whole lot of different priorities.
Yeah.
And it's really dependent on how much COVID's around, so how likely you are to get really sick from COVID, but also availability of an alternative.
Yeah.
Because what's clear, and this is what's happening in a lot of other countries, if we had no alternative vaccine, then we would have had no hesitation in moving forward with AstraZeneca for everybody.
Yeah, right.
Because that side effect is really rare.
Yeah.
And it does work, that vaccine. But because we had the luxury almost of having very little COVID, and a good alternative, we said, well, let's use that vaccine preferentially in older people where the risk is lower and prioritise the other vaccine, the Pfizer vaccine, in younger people. Now, obviously, those things are all subject to change, almost at a day-to-day basis. And what we've seen in New South Wales is the risk of COVID has clearly gone up quite a lot. And unfortunately, we even saw a person in their 30s unvaccinated who succumbed from that infection. So based on all of those things, the advice was refined, and really it's been the same advice throughout, but how it's been delivered has been a little bit tailored to the situation, where clearly if you've got lots of COVID, then it's clearly a great vaccine to use in that setting still.
Yeah, okay. And just with the blood clotting, my understanding is that we're getting a lot better at communicating to people what the symptoms are, what the warning signs are as well, even though like it is a tiny, tiny, tiny risk. Has that information been spread out into the public as well?
Absolutely. So there's been a whole lot of really good campaigns looking at how we recognise that from what sort of symptoms we should encourage people to turn up to their doctor or their emergency department to get looked at, through to the initial tests. We've got some really good testing algorithms that are really good at picking that up, all the way through to being much better at managing it. So early on, for example, when we didn't understand how it worked, that there were cases where a medicine that probably didn't help or maybe even made it worse was given. But now we know a bit more about that. We have some great medicines that do definitely help. And so that rare clotting syndrome in itself, most people who get that end up just having to take a tablet for 3 months.
Yeah, right.
So the vast majority of people will recover fully from that fairly quickly. So we need to be really careful that we don't take all the numbers of that rare syndrome and equate that with a really bad outcome, because the bad outcome from that syndrome is still only a very small proportion who get it.
That's fantastic. Can you talk a bit about the safety of vaccines in pregnancy, the relationship between that and breastfeeding as well, and even for young women who might be considering becoming pregnant? You know, how does all that work?
It's I think important to point out that early on we said we didn't have a lot of information about pregnant women as well as children, and that's not because we thought there was going to be any problems with that, but the process in which we test vaccines and approve them is that we obviously start with healthy adults, and then we gradually creep up in age, we gradually add in more comorbidities, because we want to make sure our testing process is a really safe one. So we don't start testing vaccines on people who are pregnant or children until we've got lots of really good information that's the right thing to do. So it took a bit more time to get to that point, but we do now. We have great information that particularly the Pfizer vaccine has been used lots in clinical trials and in the real world in people that are pregnant, and is very safe. And people might have heard in recent times we're getting more and more approvals in this country for that vaccine also in children. So now approved in children 12 years and older. So the vaccine's very safe in pregnancy, particularly Pfizer. And a lot of people have had AstraZeneca and didn't know they were pregnant or got pregnant shortly thereafter. And it also appears that there's no safety concerns from that. And a lot of people have asked me, what's the impact on the newborn if people are vaccinated in pregnancy? And the simple fact there is they're protected from COVID.
Wow,
that's the impact on the newborn. It's been a really effective strategy for lots of different viruses and different bugs to vaccinate people in pregnancy, because you kind of get a 2-for-1. You protect mum while she's pregnant and for a bit after, and you actually protect the baby too, because the baby gets mum's antibodies, and that's what they rely on for the first few months of life to protect them. So it's a really effective strategy, and so one that's being encouraged in a lot of places.
And so that then plays on to breastfeeding. There's no concerns in breastfeeding?
No, that's right. It's perfectly fine. Yeah, of course, you know, with all these discussions, if people, you know, are looking at those particular situations, I'd encourage them to speak to their GP or obstetrician or vaccine provider, because you know, advice needs to be tailored for individuals. But certainly as a generalisation, very safe in pregnancy.
Okay, fantastic. We're now starting to hear a lot about long COVID. And then also I listened to Peter Doherty the other day, and he talked about how some people might end up having symptoms for the rest of their life as opposed to this long COVID. Could you just talk about both of those aspects, or whether in fact they're one and the same?
Absolutely. I think if people talk about lasting effects of COVID generally, I think Peter Doherty's tweet about what time is Dan Murphy's open is going to be something that that people remember for a very long time. But long COVID is a very well recognised phenomenon now. We know that a lot of people, well, not a lot, I guess a proportion of people infected can have really long-term symptoms, persisting symptoms. So, you know, I think if people perhaps in countries like ours where we've been very fortunate to have excellent control, people sometimes underestimate the impact of this virus and think, why would I bother getting vaccinated when we don't have much or it doesn't cause problems? And, you The long COVID is a bit hard to measure, so it doesn't appear in a lot of those facts. So people, I think, underestimate how significant it is. And there are a portion of people that can have long-term symptoms, and the simple fact is we don't know really how long they're going to last, because we've only been doing this for 18, 19 months. And it may well be that people do have lasting effects. We hope it won't, but certainly a possibility. And one of the real benefits of the vaccine is that it doesn't stop people getting infected 100%, but we hope that things like long COVID and the more significant manifestations will be protected to a very large degree by getting the vaccine. So long COVID is certainly something we're still learning about.
Okay, and that was actually going to be the next question, one that we received quite from a number of people, is if I have the vaccine and I'm vaccinated, can I still transmit COVID? So what actually happens there?
Yes, you can.
Right.
And we're seeing this a lot now with countries that have a lot more people vaccinated, that we do still see cases. And I think a lot of people are misunderstanding that as being a failing of the vaccine. And so when we look at what these vaccines do, and we know this really well, is in terms of really significant disease and death, they're nearly 100% protecting people, which is amazing in itself.
Yeah.
In terms of getting a symptomatic infection, that's what those efficacy figures mostly relate to. So the vaccines are about 80 or 90% in terms of how much they prevent people getting symptomatic infection after they're vaccinated. And in terms of protecting people, it's a bit like I was saying with the pregnancy and the children, is how much they reduce transmission is a harder thing for us to measure. So we didn't have good information on that at first.
Right.
And so a lot of people said, they don't block transmission, but it wasn't the case. We just didn't know how much. But now we have a lot of really good studies where we've looked at things like household transmission, and we've looked at asymptomatic infection, and we've looked at viral shedding in vaccinated people. And we know these vaccines do help with transmission. It's probably 50 or 66%.
So when you say help, you mean by reducing?
That's right, exactly. Yeah. So that means it probably reduces the amount of people that will get infected by about half or a bit over.
Yeah.
And when people are infected, so by definition that means about 50% of those people can still get infected, they're likely to have far fewer symptoms for a far shorter duration, almost 100% protected from getting really sick, but they also are likely to produce less virus and infect fewer people.
Wow.
So it does mean we'll find people in the community that might have been vaccinated and still been diagnosed, but their trajectory and their ability to affect others will be significantly improved by the vaccine. So we need to be really careful in saying, I've heard someone who was vaccinated and still got it as a failing, is that will still happen. And the paradox that we need to point out is if you have most people vaccinated, if you look at the proportion, you'll actually see more cases in vaccinated people than unvaccinated people.
Right.
And again, that's not a failing of the vaccine, just means some of those people can still get it, but their outcome will be far better.
Yeah. So that leads nicely into another question we received, which is, we keep hearing we have to learn to live with the virus. What does that future look like? Does it mean that we're just going to need many, many more men and women like you? Or what does that mean in the community living with it?
I think we all agree now this is going to become what we call an endemic virus, like a lot of the cold viruses, and a bit like the flu.
Right.
It's a virus that's going to be around. Right. And whether it's forever or for 10, 15, 20 years, it's hard to say, but it doesn't look like it's going away anytime soon.
Yeah. So
we need to learn to control it, so we minimise its impact on our lives and our livelihoods. And what I think that will look like is we need to get as many people vaccinated as possible. That's very clear. And what we're able to do, what sort of freedoms we regain, will be directly linked to how many people we get vaccinated. And that's both in our country and globally.
Yeah.
Because basically no one's safe till everybody is. So that's really clear. And there's a lot of good programs looking at that. But then because some people can still get infected and because we probably won't get everybody vaccinated, we are going to need some simple mitigation strategies to continue long term.
Right.
And what I mean by that is definitely not border restrictions and lockdowns, because I think they're far too harsh to be considered a long-term strategy.
Yep.
They were really designed to get us to the point of having safe and effective vaccines, which we do. But what that means is we might still use masks when you can't socially distance. So wearing a mask on a plane might be a thing we do forever or for a very long time. We will need high rates of testing.
Yeah.
So if people are sick with things, and this is what we've been encouraging for the flu for a long time, is if you're sick with something, go and get a test so we know what it is and stay away from other people.
Yeah.
We hope people will have learnt to do their hand hygiene forever, because that helps with all infections basically, and social distancing as well. So we might just spread out a bit more, maybe look to, outdoor dining and outdoor entertainment a little bit more than indoor because the risk is a bit lower, and all those sort of things. So make some simple adjustments so we reduce our risk in parallel to having high rates of vaccination, and then we should be able to go about our lives fairly normally.
Okay, wow. So you've been talking a lot to the media and a lot to the community and been very gracious and generous with your time in doing this, including giving that to us today. What are some of the key myths that you've come across that you think, you'd really like to take this opportunity to help us learn about and to dispel?
Look, it's a really good point because, one thing's clear throughout all this is the misinformation has spread faster than the virus. And there is just so much out there. and a lot of things that are outlandishly unbelievable all the way through to things that I understand why people might be concerned. So, a lot of misinformation about things like microchips and other added things in the vaccines, which clearly isn't true. These days, our quality control of vaccination is extraordinary. And the ingredients of all the leading vaccines is clearly available from your vaccine provider on the internet. So that's not true. A lot of people are still sceptical of how well the vaccines work and if we need them, partly due to some of those misunderstandings of the fact that some people can still be infected. And hopefully I've explained why, that's clearly not the case. A lot of people talk about conspiracy theories and that the virus was manufactured or produced. But I simply don't think that's the case. And I think there's a lot of good work that suggests this probably comes from animals, probably from bats. And there's a virus that was very similar that was found in bats in that area 8 years ago.
Yeah.
And most of these things do originate from animals, and we have.
And in fact, we were talking about this just before. You said it was even highlighted back then that this one could be really dangerous.
That's exactly right.
Yeah.
And we've seen viruses spill over from animals. Even locally with the Hendra virus, for example. So we know bats are very good at doing this. We know a lot of these viruses are around, and this is something that they do. So I think that's what's happened in terms of the origin. But I think the key thing in our country is a lot of people underestimate the risk. And, at the moment, I think the perception of risk has gone up a little bit in New South Wales.
Yep.
But I think complacency has really crept in a lot of places because we have controlled it so well.
Yeah.
And again, a little bit as New South Wales has highlighted, it takes one person who's very infectious to create widespread community transmission that can then establish itself and be very hard to get rid of until we have enough people vaccinated. So that's why we do need people to take this seriously. We do need people to go and get vaccinated.
Yeah.
That's the simple answer to most of the questions with COVID is the vaccine. And in the meantime, do a lot of other strategies to make sure we're all safe.
Yeah. We're also talking earlier about, there's talk now in the media about drugs that are being developed, good drugs that are being developed to help manage the symptoms.
Yep.
Do you want to talk about those and when we'll expect to see those coming into the community?
Absolutely. I mean, I think when we look at the long-term control and living with COVID, there's a lot of tools we will need to be able to do that well. I think, some smart tools, some apps to help with contact tracing and, people complying with guidelines and checking in and all those sort of things. The vaccine will evolve, and that'll be a key part of our strategy. Testing, so access to great testing, which we're very fortunate to have in this country. But there's been a lot of talk about rapid testing and testing maybe in workplaces and before events and before travel, and that'll be a big part of this, as well as therapies. Yeah. So we need better ways if people do get sick from this to be able to make them better, excuse me, more quickly. And maybe even if we see a cluster or an outbreak, be able to give medicine to people around those people to protect them. And there's a lot of really good work happening in that space. That there'll be a lot of antibody therapies. So we know the vaccines help people that receive them make antibodies. Yeah. But in people that haven't had the opportunity to do that yet, we can make antibodies that do a similar sort of thing and give them to people. And so that's going to be a bit of a game changer as well. And some of those will be available in our country in the coming weeks.
Wow.
So that will be a big step forward in terms of our battle with this virus.
Yeah, okay. And we talked earlier as well about, the old adage, never waste a good crisis. Like your comments just about how this has really propelled healthcare forward and it's propelled our knowledge and understanding of viruses forward. Could you just comment
Absolutely.
on that?
I mean, I think there is a bit of a silver lining here. I think in some of the things that will be advanced as a result, I think health literacy. I mean, these days you can't go into a pub or a shop and people aren't talking about vaccine efficacy and herd immunity and all those sort of things. And, previously, myself and my colleagues were the boring people at parties talking about flu vaccines and hand washing. But now that's the thing everyone wants to hear about. So, we've been given a bit of a voice.
You're getting many gigs to do that, emceeing
not
weddings
enough,
and
not
things.
enough. So I think health literacy generally and, knowledge about infectious diseases and how to prevent them will have been accelerated by all of this. And hopefully some of those things will continue. But certainly research and development of new drugs and vaccines particularly, I think has been definitely accelerated. And hopefully, even for example, in this country, we'll have some manufacturing capacity for a whole host of vaccines. And, mRNA technology, interestingly, wasn't developed to make vaccines. It was developed for therapies, particularly for cancers and other rare diseases. And so once we get this under better control, it's hoped that we'll be able to move on to other infectious diseases, as well as hopefully other diseases in all sorts of other areas. And, we've certainly learnt to cooperate and collaborate better in science and research with this when we had a common goal. Yeah. And, I recall involved in some of the vaccines before this happened. We used to fight to try and get people to help us with certain components or certain research. And, when this all started, the floodgates opened and everyone was sharing information, everyone was sharing expertise and equipment. And so that really facilitated a lot of the rapid development of, the vaccines that are making such a difference now. So hopefully some of that will continue into the future.
Yeah, fantastic. Well, I think that pretty much covers the list of questions that we had. We're lucky that we've got some people here in our head office in North Quay. If there's any questions, or if you'd like to put anything through in the chat, we've got a few minutes still left with Paul. I think that's good. I think our processes have worked to actually get information from people and give everyone the opportunity to ask Paul a question. So I would like once again to sincerely thank you for your time. Paul didn't really know me from a bar of soap, and I got given his phone number and I said, I was told, talk to this gentleman. He answered the call. I explained what we were trying to do, and within 10 seconds he said, yep, I'll come in and do that. That's a really good thing. So Paul, we're just incredibly grateful that you have done that. We take our role in the community incredibly seriously. We're working with a vulnerable group of people, and we think that we have to be informed ourselves, and so that we want to be able to take this information out and share that as well.